morning. I'm Dr. Tim Allen Williams, Chair of the Department of Medicine here at University of Louisville. And it's my distinct pleasure this morning to introduce our introducer for our speaker. Our speaker is Dr. Shawn Kwatra, who is the Burnett Professor and Chair of the Department of Dermatology at University of Maryland School of Medicine. But he's actually going to be introduced by the living legend himself. Not very often that you get a legend who can actually introduce the named lecture for himself. And that is Dr. Jeff Callan. Dr. Jeff Callan has been at University of Louisville for over 3 decades, and he is our division chief in dermatology. He has educated so many people and built a real legendary and sustainable model for dermatology here in Louisville. And we really appreciate being able to be present for your own named lecture. Okay. Thank you, Dr. Callan.
Sure. Okay, so I have the pleasure of introducing Shawn Kwatra, who's, as Tim has already said, is a professor and chair of the Department of Dermatology at the University of Maryland, and it's a named professorship. Kim, actually, I've been here since 1977, which is almost 5 decades, not quite, but it's a long time. Yeah, I've seen lots of changes. Much as there's change, there's a lot of things that remain the same, though. So when I can't remember, since you brought it up, the named lectureship was created, I think when I was program director for about 25 years, and my wife said, "Oh, we ought to do something to, memorialize. I'm not dead, but that would remember this." And we through generous donations, we gave to it as well. But I mean, through generous donations from faculty at the time, from prior residents, from friends of mine that are all across the United States. We raised sufficient funds to have more than one lecture these days, because University of Louisville has it's in an endowment, and they have allowed it to develop appropriately. And so we have spending limit that allows us more than just one Callan lecturer. So without further ado, I've invited to speak today Shawn Kwatra. He's going to talk about itch, which is a very common problem that we see across the spectrum of medicine. As I told Kim and the people who joined us at dinner last night, that basically when I came to Louisville, I built my practice from scratch. And then Kim sort of brought up the idea that people were itching to see us. And so without further ado, let me let you take it over.
Thank you, Dr. Callan. We had a great dinner last night, and Dr. Callan's the greatest host. So he asked me what I wanted for breakfast, and I had a selection, and he made just the best omelet of all time. And also, he took a lot of time yesterday. I really appreciate it, to show me all sorts of great things in Louisville. We went to this incredible art exhibit. Who's the artist?
Yayoi Kusama.
And it was this room we went into that was like mind-bending, mind-altering. And we went to a candy store that was like there in the 1800s, I think. It was just amazing hospitality. So thank you so much. Dr. Callan really is a legend in dermatology. I think, to me, he's the most respected figure in all of dermatology. So it's really important. It was really helpful for me to be able to spend some time with him. You guys are so lucky you have him. I'm going to be talking about itch, and it's actually a great topic for an internal medicine grand rounds, because everybody sees it. It can be associated with a lot of diseases. It's super complicated and can be confusing. So it's a good topic. These are my disclosures. So we just want to talk high level. What are some etiologies, insight into pathogenesis, a basic workup, and also spectrum of new therapeutics. Believe it or not, itch was long forgotten, but now I believe it's probably one of the hottest areas of development in all of medicine, with billions being poured in every year for development and new therapeutics. So this happened very fast. It's very fast developing. And itch is a very commonly reported concept in the popular media. So Lisa Sanders is one of my favorite writers, and she has this column for New York Times Magazine where she goes through difficult diagnoses, and her work was actually the inspiration for House MD, which is full of diagnostic mysteries. And so I wanted to touch on two of these diagnostic mysteries relating to itch that she featured in the New York Times Magazine. One of them was about an 82-year-old man who had this terrible itching out of nowhere, just terrible itching. He was actually found to have recently had about 10 cats that he'd started taking care of, actually had sky-high blood eosinophils, and also had toxariasis, actually parasitic infection that he had. The other patient here is a 40-year-old female who out of nowhere had terrible itching and was actually found to have a Hodgkin's lymphoma. So with itch, you gotta have your spidey sense up for anything: liver disease, kidney disease, lymphomas, malignancies, all of those things. So let's talk broadly. Itch is definitely a dermatology symptom, but it's one of the most common symptoms overall. And itch, we also know that there's tremendous health disparities in itch. I tell people that itch is actually a good way to study health disparities because there's so many different factors from your environment that also factor in. Pollution, smoking, access to nourishing food, food deserts, all of these things, because these nerves that are in the peripheral skin can be activated and modulated by your environment. And broadly, when I think about the burden of itch, because it's very hard to get the burden across sometimes, I like to think historically. There's actually a village in India. And I told my grandmother before she passed that I wanted to study itching. And first she laughed, which is a common thing that happens. But then she told me about this village in this tribe called Nagaland, where what they found is that if someone is terribly itchy, they could put if someone commits a crime, they can put them in prison for 10 years, or they can put them in this triangular hut and give them an itch-causing substance, a bean plant that causes itch, and have them just be in there for 1 day. And they found that being in 1 day of this cage and itching is actually more preventative than 10 years in prison. So they actually have this as a punishment system in a tribe in India, where if you act out in the community, you have to go itch for the whole day. And they found it's tremendously effective, which to us highlights the burden of disease. And the other historical remnant is Dante's Inferno, where it talks about all the different layers of hell. And there's several different rings of hell. One of them is being frozen in a lake. Another one is your blood boiling. Another one is feces raining down from the heavens. And sandwiched in between all those in the eighth ring is unrelenting itch. So that's the burden of what we're talking about. I think one of the most really under-recognized terrible conditions that destroys people's quality of life. I told some folks last night that my college friends made fun of me when I told them I wanted to study itch. They're like, be a real doctor. And so I did this study because I wanted to highlight quality of life, but also because I wanted to get back at my friends. So we did this study where we took all the patients I was taking. It's great, right? All the itch patients that we were seeing, and we had them fill out a quality of life questionnaire that's validated. We compared it to all the conditions all our medicine docs think are really important, right? So we got some cardiologists, heart failure, stroke. Oh, okay. So chronic itch, falls in a little bit worse than having a stroke, heart failure, diabetes. So that's what I want you guys to think about. When you think about itch and someone tells you they're itchy, think about, man, this could be worse than having a stroke, pretty close to Parkinson's disease. So that's what we're talking about today. And I showed it to my friends and they're like, okay, this is an important concept. And I think that burden of quality of life impairment is a number of things. First, it's sleep disruption. I know, when I don't sleep, I'm totally insufferable the next day, but it can lead to impaired mood. It can lead to impaired work and daily activities, and then overall quality of life. So that association with sleep is very important. When we looked at itch patients who can't sleep at night, they actually have higher cardiac biomarkers. So high C-reactive protein levels, actually high brain natriuretic peptide levels. They actually have more cardiac events too, patients who are itchy, who can't sleep at night. So by simply asking patients about their itch from 0 to 10, how itchy are you in the last 24 hours? If someone's over a 7, you know that they have higher circulating IL-6 levels, acute phase reactants, C-reactive protein levels, they're not sleeping well, and they actually have higher overall cardiac risk as well. So let's go through the journey of itch and what it is. It's actually really fun. So you take your hand and you scratch your skin, and this is under the lens of what's going on. You have the epidermis, and you have these nerves, thinly myelinated A delta fibers and unmyelinated C fibers that are right there out at that barrier with the epidermis and the environment. These nerves go through the dermis where you have a variety of immune cells. You have mast cells, eosinophils, macrophages, T cells, basophils that are all secreting a variety of cytokines that are activating these nerves. And then you actually have transmission from the skin. The cell bodies of these neurons are actually in the dorsal root ganglion. And that itch message, this neural transmission pathway, goes up the spinal cord to the brain, the thalamus, and it projects to many different brain areas. So this itch sensation, we talked a little bit about those fibers, the nerve fibers, and the transmission pathway, and we'll zoom in a little bit more. These are the two C fibers and A delta fibers that are very much so implicated in itch pathogenesis. You also have other types of cells here, like Merkel cells that are involved in deep static touch. But we're learning a lot more. Actually, our lab right now is studying Merkel cells in chronic itch too. And so we think there's actually a role for some of these other cell types. This is a biopsy directly from one of our itch patients who had terrible, uncontrollable itch. And what we found is in the dermis, you have this hypercoiling of these nerves, this branching of these nerves that's actually transmitting a lot of that itch sensation. So now let's go to the spinal cord. Here's what we have going on in the spinal cord. This is actually the dorsal root ganglion. You have this docking station. And you actually have a very itch-specific molecule, gastrogen-releasing peptide, that has been found to be specific to itch, but not to pain. And in the spinal cord as well, the dorsal root ganglion, where you have crossover, you have a lot of these neurotransmitters like glycine, GABA, dynorphin. So if you ever give gabapentin for itching, and we know people use it for pain as well, you're actually modulating itch at the spinal cord level as well. And then finally, you have different brain areas of projection. I know actually I have hives and I also have eczema. And when I get super stressed out, which is a lot, because I took a new job as a chair and it's very hard. And everybody complains to you. I know you guys know what I'm talking about. So, which happens all the time. I actually, sometimes when I'm stressed, I break out in hives. And it's actually top down where actually the neurons are being activated and it's going from the brain through my spinal cord to the brain, to the skin, and they're releasing these neuropeptides, calcitonin gene-related peptide substance P, and then that's causing the immune cells to fire. So it actually is totally related here, where itch is one of the highest placebo effects too, because you have that neuronal involvement. So this takes us to a crosstalk between the neural and the immune systems that I think is just really elegant science, where you have immune cells, you have neuron endings. This is really the front line here for many new therapeutics. So billions and billions of dollars are being invested and being made right now with therapies that are modulating many of these different receptor targets that are on the peripheral neurons. So when we think about itch, when I think about itch, I think about it a lot like a lightning strike. You may not have it for a long time, but when it comes, it's so paroxysmal, it comes just with that thunder, that lightning. So I wanted to solidify what is actually going on in the skin. Well, you have these inflammatory medias, you have immune cells that are secreting cytokines. And then these cytokines are actually activating the peripheral nerve ending. And then you have sodium channels that are depolarizing calcium currents that are being activated, and you have the itch signal. What you can also have, like I showed earlier, is you can have neuropeptides or neurons that are actually releasing neuropeptides that are causing immune cells to secrete cytokines. So this is another patient I had. He actually had our disorder, many of you know, prurigo nodularis, but we made sure it wasn't a fungal infection first because it was so exophytic. And this patient had terrible itch. These are the biopsies again for this patient. So we'll go back to this coiling that we're seeing in the dermis, this hypercoiling of the nerves. we gave him thalidomide because this is before we had new therapeutics. And I had to counsel the patient, you could have a pulmonary embolism and die. And he said, of course, I want to take it because I can't itch any longer. And what the thalidomide did is you can see that in a healthy patient, you're not going to have this coiling and you're going to have less nerves. Actually, you're going to have more nerves through the epidermis. But what the thalidomide does is it actually knocks out some of this dermal innervation and hypercoiling of the nerve. So it actually causes sensory neuropathy, but it actually stops what's happening right here. So it stops the neuropeptide release from those nerves. So actually many patients, my mom has diabetes, and she actually started developing this itch condition, prurigo nodularis, where you have these lesions. And what I think about with diabetes, you can have all sorts of peripheral neuropathies peripherally, right? Well, one type of peripheral neuropathy we are hypothesizing is that you have damage from the excess of glucose to the nerves directly. And that neurogenic insult to these nerves causes neuropeptides to be released and you can see that these neuropeptides is actually staining these number of patients where you have more of these neurotransmitters in the skin, are then causing the immune cells to get revved up and secrete cytokines. And so this is actually the micro itch scratch cycle. When you're actually scratching your skin, this is what's going on. The nerves are releasing neuropeptides, the immune cells are releasing cytokines, and that's the transmission pathway. So I'll go through a few mediators that are actually relevant across medicine for itch. Like I said, there's so many new mediators that are being studied and understood on a daily basis that now I think itch biology is revealing all sorts of breakthroughs across cough, irritable bowel syndrome, all sorts of diseases. We're understanding more and more. So let's start with histamine. So histamine is really misunderstood because everybody thinks, oh, you're itchy, take antihistamines, right? So where does that actually come from? Well, the mast cells, of course, are releasing histamine. And the site of the release of histamine is important. If it's in the papillary dermis, so higher up, you get hives or urticaria. If it's deeper, then you get angioedema, more pain than itch. So histamine is important, but it really doesn't work as well as we think it does because there's a lot of non-histinergic pathways. So actually a collaborator of mine discovered this new pathway. This is like a new histamine. It's called MRGPRX2. And a company, Escient Pharmaceuticals, my collaborator actually raised over $100 million, and now they just got bought for $700 million by Incyte, and they're targeting this drug right here as the new modern day antihistamine. So that's fast-acting science that's happening from animal models to humans. Opioids are very important. So everybody knows if you give morphine, you itch a lot. But the converse is also true. So kappa opioids are very important. More kappa opioid activity results in less itch. So there's the company, Therapeutics, that again raised over $100 million to study a new drug, a kappa opioid agonist in chronic itching that we'll get to later. There's the JAK-STAT pathway. So JAK1 is in the intracellular domain of several pro-inflammatory cytokines involved in itch, from IL-31 to IL-4 and IL-13. We have multiple of these approved now for atopic dermatitis, and you can see that they're actually on this intracellular domain here. You can see IL-31, IL-4, IL-13, a lot of these different cytokines all signal through JAK inhibitors. There's a role for cannabinoids in itch, where you have increased cannabinoid tone helping to reduce itch. So this is being exploited and studied a lot as well. All right, so let's transition now to helpful stuff. We talked about pathophysiology and why itch is important, but let's actually get through some helpful clinical pearls. So first, I want to talk about approaching the chronic itch patient. So who has ever treated an itch patient in their lives? I know you have, Jeff. All right, everybody. Who just loves it? That's what you look forward to every day. That's just like yeah. And so what I was trying to capture, because there is this disgust. My wife, this is a true story. My wife's a dermatologist. She's a pediatric dermatologist. We met at Hopkins. We both did our training there, and we were getting married. And so I was like, okay, are you gonna change your name? This is a cool thing to do. And I was like, you're ready for you to change your name? And she's like, no. And I was like, okay, look, I respect that. I was like, do you mind if I ask why? And she said, well, I don't want to change my name, honestly, because if I say I'm Dr. Kwatra, then I'm going to get itch referrals because we practice at the same time. And that is honestly the reason my wife did not change her last name. And so that to me was like, this highlights something that's going on here, right? We have a big problem. It probably stems from uncertainty. So, yeah, I've been really thinking about this. Everywhere I go, people are like cringing, like, oh, man, yeah, I want to learn more about it, but it's just, I don't want to see the patients. And so I went out there and I started this itch clinic. Everybody's like, are you crazy? This is the opposite of Mohs surgery, right? The Mohs surgeons make the most money, they have a great life, and then the itch patients take forever. You get 1,000 messages, you can't really have a clinic. It's really hard, actually, to do it. So I use my AI. I don't know if you guys use a lot of AI. I know you use ChatGPT. I use this the Microsoft tool to look a lot more. So I wanted to use all of the history of knowledge in the world to summarize, the doctor's approach and their thoughts and their emotions in treating itch patient. This is what I came up with. Pretty good. So it actually, like, what it shows is that there's a lot of uncertainty. This happens all the time. People are just not sure what to do. And then it goes to thoughts about other things. You have other organs, you have livers, you have kidneys, you have organisms, you have hearts, you have aliens, which I'm still not sure about where the aliens came from, but that shows you how the thoughts scatter because there's not a great unified approach to treating itch. So we have attempted to help to harmonize this, acknowledging this is one of the most difficult things in medicine. But we've attempted to harmonize what's a very straightforward approach to, you see an itch patient, how can you harmonize this and give good care? For certain questions. So duration, how long have you had the itch, right? If it's longer than 6 weeks, you can be more chronic versus acute. Is it localized to just your scalp or your arms? Then maybe we're thinking it's a neuropathic or nerve issue or versus being generalized. I ask everybody about a history of atopy. So any history of eczema, asthma, seasonal allergies in you or your family, that's shown to be really helpful to point you towards more immune biased itch. And then back and neck pain. Those are good questions because oftentimes itch is localized. Patients who have back and neck pain, oftentimes that's a good suggestion that it's the nerves that are being impinged upon that are causing chronic itch. And then there's so many other things. I like to just touch in on these B symptoms. Timing is also important for understanding malignancy risk stratification. There's so many different things, HIV, hepatitis C, that of course make you more likely to itch. So you use your appropriate context to check in about that. So those are all big things. These are some physical exam things that we found to be helpful. So patients sometimes will say, do you have a positive ice pack sign? Jeff Bernard, one of the former editors of the JAD, and a great guy, came up with this sign. So if patients actually put on a lot of ice packs, that tells you it's more likely to be neuropathic itching or brachioradial pruritus, which is emanating from the nerves, which transmit itch, but also pain and temperature sensation. The hands and feet, that can be suggestive of cholestatic price, but it's not perfect. It can be all over. I usually just kind of ride on people's skin a little bit, just to get a sense for how dermatographic they are, how jumpy their mast cells are. If you ride on it, it hives up immediately. You have a good sense that there's a lot of mast cell activity. I look at everybody's hands, including mine. I have very thick, manly palms, I call them, but actually I'm just an atopic. And you have hyperlinear palms as well. And then you can look for papules or burrows or plaques or blisters associated with bullous pemphigoid. So this is super complicated, but we made these diagrams to try to harmonize your approach. When you see an itch patient, first thought is there a dermatologic origin here? Is there inflamed disease skin? Or is it normal appearing skin or secondary excoriations where then you'd think about Pandora's box, all these different internal medicine types, diseases and things like that. So we actually made this algorithm that we're still working on, we're still working through for itch, but I'm going to walk you guys through it to help with the workup of itch patients. So broadly up top, again, the first decision point here is it a clear dermatologic cause in your exam where you're seeing a primary rash or not? So we're going to walk through each portion. So patients itching over 6 weeks, is there a primary dermatologic cause? These are all examples of varieties of dermatologic causes from atopic dermatitis, psoriasis, prurigo nodularis. We have hypersensitivity reactions, mycosis fungoides, hives, erythrodermas, all sorts of things, lichen planus. Well, in those situations, we can handle them pretty well. Atopic dermatitis is most common, as all the derms know, in the antecubital fossa, also behind the knees. One thing we've been studying a lot in Baltimore is racial differences in atopic dermatitis. And if you think about it, the criteria for atopic derm was made by two gentlemen, Dr. Hanifin and Rajka from Oregon and the Netherlands, not the most diverse areas on earth. So is focusing on flexural areas, but what we actually see in African American patients is we see a lot of extensor involvement on the hands. We see papular involvement as well in these different domains. And in our lab, we're studying the different immune axes that are involved and finding that in addition to type 2 inflammation, you have activation of some other immune axes like type 22 as well and other immune axes. You can see here as well, more extensor. These are some of our patients, more extensor involvement in African-American patients. You can see many of our Asian patients also have this dusky dyspigmentation as well, and actually elements of more psoriasiform scaling as well. So in our lab, we take biopsies, we do blood draws, and we correlate a lot of the phenotypes that we see with the molecular etiologies as well. So we tried to adopt some new criteria. So you can have flexural identification and itching to have eczema, but you can also have psoriasiform scaling, dyspigmentation, and many of these secondary papules, follicular papules, especially in younger children. That's what we see a lot. There are a lot of disparities in atopic dermatitis, so higher rates in Black children, 6 times more likely to have persistent atopic dermatitis, more likely to develop subsequent asthma. Again, there's more exposure to secondhand smoke, traffic-related air pollution, you can see here, and there's actually an urban microbiome, so metropolitan urban areas have increased risk for AD along with that air pollution, and also tobacco smoke. So another reason why itch is a great barometer also of social determinants of health, because all these different factors contribute as well. And then coupling that, a lot of our African American patients are less likely to have visits for atopic dermatitis in general. Our clinical trials are very underrepresented for many of our African American and Asian patients as well. And finally, many of our new therapeutics have very poor access. So there's problems with recognizing the disease. There's problems with and the appropriate morphology in different ethnic groups. There's problems with getting drugs to them. There's problems with disease progression and other comorbidities. There's a problem with trial representation, and there's actually also problems with getting these new therapeutics once they're approved. So itch is actually really a great analogy here for what's going on more broadly in society and many of the disparities that we face. So we're just trying to summarize all of the different factors. And one thing that we've been taking a lot of time studying now is the entry of microbes and pollutants. And a lot of our work has come back to food deserts actually causing gut microbiome changes as well that also seem to be driving a lot of the immune response. And this summarizes kind of what we think is going on. And also my lab in particular takes a bench to bedside approach where we do genetics and epigenetics, we do microbiome profiling. We also look at the disease burden, and we're actually actively trying to make our goal is to have the most diverse clinical trial site in the world in West Baltimore. So we're actually putting a lot of resources towards recruiting a lot of African American patients. And our goal is our one site alone, hopefully we'll be able to have enough phase 3 trial subjects for these studies that have been woefully underrepresented. So atopic dermatitis also has comorbidities like hives, food allergy, allergic rhinitis, a lot of these other conditions as well. So that's just something else that I want to make sure everybody keeps track of. Another important reason to be mindful of atopic dermatitis. Okay, so let's go through our algorithm. So we think it's dermatologic cause. If we know what it is, we can treat it pretty good. Dermatologists can take care of it. And if we're not sure, we can do biopsies. We can do all that stuff. We have great workflows for figuring things out. So let's go through a patient. This is a 43-year-old female, very itchy, 10 out of 10. She had tried antihistamine alone, also tried other things like non-specific immune modulators, methotrexate, steroids. This is just a straightforward case treated with dupilumab every 2 weeks, and her itch went from a 10 down to a 2. You can see that dusky pigmentation and that erythema right here. This is kind of hard to appreciate. In a white patient, you have to be very clear that erythroderma and that redness. In a skin color patient, it's hard to appreciate, but you can see here the differences. And so what this does is these scales for our trials quantify erythema. But if you can't see it as well, then what you're doing is you're undercalling a lot of patients. And so the clinical trials may not be representative. And also when you're giving the drug, you have to hit a certain threshold for involvement in the skin to be able to qualify for drugs too. So that highlights one of these issues. Okay, let's go on to systemic etiologies of itch. We got the internal medicine crowd here. So itch is kind of fun in all the things that can cause it. It's kind of terrifying too, but you can have lymphomas, thyroid disease, hepatobiliary disease, liver and kidney function, diabetes, polycythemia vera, kidney disease, malignancies, infections, iron deficiency. I mean, we get to really be house MD here and uncork what's going on with our patients. So what's the straightforward way? This is not necessarily the way to do it. It's the way I do it. So it's the way you can think about it. I start with a very straightforward screening. So if someone comes in with itch, they don't have a primary dermatologic eruption. They have just normal appearing skin or just scratch mark excoriations. And everybody will get a CBC with differential. I always get the differential because there's a certain cheat code here. If you see the bloody eosinophils and they're high, that's basically a biomarker of type 2 inflammation. So actually in recent years, we've started to also order IgEs more because IgE is similar to bloody eosinophils in that they're both biomarkers of type 2 inflammation. They don't have to be high, but if they are, then you have a good sense it's the immune system that's going on. You also can check for any hemoglobin dyscrasias, anything like that. I usually get a CMP, but you can see you want to check for specifically for liver and hepatic dysfunction, renal function testing, and you want to do either fasting glucose or A1C and thyroid function tests just because you have a quick fix. So that's what I'd say for all these itch patients. And that's where it gets a little complicated. Well, what about all these things? Someone could have HIV, they could have hepatitis, they could have heavy metals in their blood. And I say for these, workup is indicated by risk factors in the H&P. You can always go there, but I usually start with a tight workup. So let's go through uremic pressure. So this is common in patients with end-stage kidney disease. It affects up to 80% of patients on hemodialysis. What are the treatments? Narrowband UVB phototherapy, gabapentin, that's renally dosed, so low doses like 100 milligrams a few times a week, especially after dialysis. Pregabalin as well. Recently, there's a New England Journal of Medicine article about diflucapelin. So again, this is a kappa opioid agonist. This was injection, but now it's being formulated as an oral agent as well. So kappa opioid tone is actually, if you increase it, it's able to downregulate some of itch. Cholestatic pruritus, so this is due to any cause of cholestasis, thought to be related to elevated bile acids and worse on the hands, also the feet. So the treatment for the cholestatic itching is bile acid sequestrants, cholestyramine, rifampin, naltrexone, or sertraline. So I'll show you guys another patient and some of the workup and dosing that we like to use. So cholestyramine, also our opioid antagonists. Prurigo nodularis, I'm showing you guys, is a really interesting condition because our lab actually published a study last year where we found that this disease that disproportionately affects African-American patients and Asian patients as well is actually an analogy to itching in general. So people have a polygenic risk score. Our lab performed the first genetic study of this. There's a polygenic risk score that predicts whether you develop itching with lesions or on normal skin. So that's genetically encoded. So that's why for these patients that present like this, many of our African-American patients as well, have a tendency towards fibrosis across diseases. We do a similar workup as a chronic itch patient. So CBC, a CMP, diabetes screening, we do the same workup. And actually, I wanted to share a recent study that our lab did on endotypes in these diseases because it highlights a little bit more about racial differences within these diseases. And then finally, we have a new therapeutic as well that's available. So nemolizumab is an IL-31 inhibitor. And we just published this last year, and now the drug's available for prurigo nodularis. This is a global study that I helped design and conduct as well. And it's approved for this condition, but it's also going to be likely approved for so many other itch disorders, atopic dermatitis, bullous pemphigoid, and I think it's going to work for so many itch patients. So we're expecting millions and millions of itch patients to have this drug soon. It's really interesting because IL-31 is a direct neurotransmitter for itching. And so if you stop IL-31, you're able to stop itch very, very fast. There's perineoplastic pruritus as well. So polycythemia vera, as we talked about in the blood, the hemoglobin levels, you want to check that. Hodgkin lymphoma and non-Hodgkin lymphomas, you can see pruritus develops in a lot of these cases. T-cell lymphomas as well, and many of our PD-1 inhibitors are actually also causing itching. So a lot of people ask me, when do you screen for malignancy and itch, and what are some of the indicators that can help you? I think we can look through the literature and get some clues. So there's a study that showed that if you have chronic itching, you're a little bit more likely to develop a hematologic malignancy or a bile duct malignancy in particular. When we looked as well, we found very similar data here. So gallbladder and biliary tract, liver disease, and hematopoietic disturbances. So age over 60, male sex, and liver disease, those are all predictors of malignancy development in patients who have chronic itch. But what's very important here, you can't just screen everybody, as it's the timing of their itch. So this is a clinical pearl you can enact in your next clinic. The incidence is much higher, is twofold higher for malignancy in the first 3 months after the itch started. And then it decreased throughout the first year. And really at 5 and 10 years, you have just the general risk of the population. This is from a Danish cohort study. So this helps me a lot actually too. So when I see these itch patients and you say, how long have you been itching? If it's for less than 6 months or a year, then really have increased sense for, hey, do you have any fevers, chills, weight loss? You could order a chest x-ray to look for lymphoma, things like that. We looked also in patients for hematologic malignancies, and the same thing happens. In the first year, you're much more likely to have a concomitant malignancy. So that's why just asking about the duration can help you risk stratify, ask about those B systems, and then decide whether you want to do a workup. So less than 12 months. And some things you can do is chest x-ray, PA, and lateral. You're specifically looking for, any type of mass, lymphoma, a serum and urine immunofixation, or lymph node ultrasound. Again, less than 12 months. If people are itching more than 12 months for several years, they're pretty close to general population risk, and just get age-appropriate screening is the appropriate way to go about it. So now we're going to go into a different category. You've already done your screening. You already, looked and thought about malignancies. What happens then? And this actually happens all the time. Like most of the time, I'm just ordering things and nothing hits. So then we have a number of conditions that all convey we have no idea what's going on. They called it, before it was senile pruritus, how offensive, right? And then it was chronic idiopathic pruritus, that's fine. Now we're using chronic pruritus of unknown origin. Well, it still means we have no idea what's going on. But it does help us kind of have a placeholder term. So I'm going to go through a little bit more about this. So this is having itching greater than 6-week duration. It's thought to be due to immune senescence. So you have a shifting in your immune cells from type 1 to type 2 inflammation. So more IL-4, IL-13, IL-31. Oftentimes in these patients, not necessary, but oftentimes I've been checking more because we're detectives with these patients. They oftentimes have very high blood eosinophils and IgE, which are helpful markers to know that it's the immune system. And when we studied these patients, we found that there's actually variable response to treatment. If you have higher blood eosinophils, you're much more likely to respond to immunomodulator therapy. So you can see here with increased blood eosinophils, these patients responded much better to therapies like methotrexate, intramuscular triamcinolone, dupilumab, off-label therapy. And we're publishing right now on IgE as well. And then patients who don't have these markers are more likely to respond to gabapentin, neuromodulating agents, because we know that neuropathic generalized itch can also present in a similar way. So this isn't perfect, but it's helping to inch us a little bit closer. So I'll show you a few examples. This is an itch patient, 89-year-old female, 10 out of 10 itching. This happens all the time. And oftentimes they come with their children too, and the children look so stressed out. I can't even imagine having your parents be so itchy. It's really a sad situation. So this patient had 8-month duration, no improvement with all sorts of stuff. And you can see her eosinophils were 5.1%, elevated absolutes as well. And she had actually 90% improvement with dupilumab therapy. This is another patient who had 10 out of 10 itch. She had significant improvement here. Here's a male who had a history of lower back pain and low blood eosinophil count. And actually on his x-ray of his lower spine had multifaceted sclerosis. And what we think is happening is this disc space narrowing is causing an impingement on the nerves, this is triggering neural sensitization. This patient didn't respond to immunomodulator therapy, but got a lot better with gabapentin as well. So based on some of this stuff we approached Regeneron and Sanofi, and there's a phase 3 trial ongoing right now for dupilumab for chronic price unknown origin, but it's stratified based on these blood biomarkers. And so the real issue with these itch patients is you can't tell if it's the immune system or the nerves. So we actually are submitting some more NIH grants and studying this in our lab because we want to develop like careful and thoughtful blood biomarkers. We think serum TARC levels are helpful. So when you get these itch patients, you can get a blood biomarker panel that can help point you in the right direction for therapeutics as well. The thought is like you do flow cytometry, you can do blood and serum levels, but you could also do blood flow cytometry, which is what my lab does to see are the T cells, like what are they secreting, which cytokines peripherally to help guide treatment, especially a lot of new biologics. I have a sense that's the way things are going to go eventually.
Dr. Kwatra?
Yeah.
How often do you have the patient, like the elderly lady that you had who's very itchy all over? Are you ever doing like flow on a patient like that for Sézary syndrome? Are you seeing that a lot in your itch clinics? Because that patient does look pretty like almost erythrodermic to me.
Yeah.
Are you getting that a lot in your cases or not? Is that pretty rare?
It's hit or miss kind of based on the presentation. Yeah, I think she may look a little bit more erythrodermic. In real life, it wasn't as much redness.
Yeah.
But yeah, if there's more erythroderma, absolutely, I'll get that flow workup.
Okay.
I think the back looks like it a little bit, but overall, it was not as much activity. But that's a really good question. Yeah, I do that anytime we have any indication. Okay, so let's get back to it. So the problem here with itch, I think in general, is we can kind of sort through all of this, but where I struggle, and I think the field struggles a lot, is when patients have neuropathic itch. I think this is a really hard problem for doctors. And it's a problem because they come to see dermatologists, and I have to say this, I'm going to try to help you, but this is not a skin problem. It's like in your spinal cord, let's get you a neuro says this isn't a neuro problem. This is a derm problem. And so we're all pushing patients back and forth to each other, and the patients are getting lost. So I'll try to show you guys a little bit more. These itch syndromes, I know you all see it, scalp itching all the time with no rash, and they have dysesthesias, and there have been studies showing that that's actually related to cervical nerve, disc disease, nerve impingement. There's notalgia paresthetica in the upper back where you have that focal itching. My wife has this. It's very annoying. She makes me scratch it in bed before she goes to sleep. And so it's like just over one shoulder blade. And it's been shown to be related to thoracic nerve impingement as well. Then brachioradial pruritus related to the cervical dermatomes, C5, C6 in particular. Lumbosacral involvement, so L4 to S2. You can see that you can have anogenital pruritus. Many studies have shown that as well. So brachioradial pruritus is on the arms. Here it's common in tennis players. We talked about that ice pack sign, notalgia paresthetica on the back here as well. So just showing you guys a simple case, a straightforward case. This is a 53-year-old female, had this itching of the left upper back, tried a lot of antihistamines, didn't work. And you can see the treatment's pramoxine lotion, so an anesthetic, low-dose oral gabapentin. I give people muscle exercises. I can share that with you all. There have been some small studies that if you strengthen the musculature, that can help with itching as well. And this is a great study about the scalp dysesthesia related in the cervical spine dysfunction. So we had a lot of these patients, and it's been very difficult because we've had to treat these patients. They come see me because I declared I had an itch clinic, and so we have a really hard time. So one thing that we did, because no one would help, so we kind of used from the migraine literature where we did something called a bedside greater occipital nerve block. And I have two left hands. I am very not coordinated, but I was able to figure this out. So if I can do this, anybody can do it. So basically what we did is we drew up bupivacaine 0.25%. And the thought is, okay, we know the nerves are causing this itch. What if we just used a long-acting anesthetic to break up that itch scratch cycle? So we injected 6 mils of 0.25% bupivacaine, 3 at each point here, and we angled it at different angles, mirroring the branching of the occipital nerve. So this is the patient, 65-year-old male, itching 10 out of 10. Look at all these things. I tried everything. Nothing worked at all in him. We did an X-ray. We did an MRI, and we can see it very clearly. I mean, that's pretty clear. There's something going on that's causing the itching right there, the multi-level disc disease. areas of cervical stenosis. Even this, I was like, oh, is that psoriasis? What is it? No, failed at everything. It's actually the nerves being hyperactive that are then causing the secondary scratch and secondary lesions. So we did this technique, and you can see the itch went down immediately, and it popped back up after a few weeks. We did it again, and it went down again. And you can see this is him after. And we actually ended up doing and I may show the derm residents and the derm team a little bit later this morning, the video of it. We ended up doing actually a greater occipital nerve ablation with IR. I convinced IR. This was like a proof of concept, and some of these IR docs were doing it for migraine, and I just begged them, and they did it, and then now the patient's doing much better. So it's just a test hypothesis. So it shows us, I try to tell all the residents and docs that every patient opportunity is an opportunity to kind of change how we treat these patients. So we did that, and now there's this new field. I tell everybody if they want to do fellowship with me, interventional itch. It's like going to be like change. I tell everybody I'm looking for fellows, interventional itch. It's coming. So just a few key points here. The initial goal for evaluating these patients is itch dermatologic or non-dermatologic? Screening laboratory workup, so blood count, complete blood count, hepatic renal testing, thyroid function testing, and diabetes screen. And individuals who have itch of unknown origin, you can use some of your blood biomarkers to see if it's more immune in nature. I usually just treat as immune as well first too. For treatment, I want to make sure I spend a few minutes focusing on treatment because I know that's what everybody wants to know. Itch management requires clinical phenotyping into these different subtypes. These therapies modulate the neural and the immune systems, and oftentimes requires a combination of therapies. So when you're treating these itch patients, this is the gap, because you see the patient and then you're like, okay, well, what do? I tried, right? So a lot of people giving antihistamines. Yeah, they're given all sorts of stuff that everybody's just passed along, all on the medicine floors too. You know, all these patients are itchy, they're all on Benadryl or this or Camphor or all that. So I spent many hours making this diagram of my itch toolbox. This is it. I spent about 7 hours in this biorender, picking all the images. So you can see here, there's like a lot of stuff in here. There's like a lot of cool stuff that we have. There's a lot of tools. So I wanted to highlight some of those tools. Okay. First thing, high placebo rate in itch, as high as 24% itch reduction because of that central nervous activity. So this is actually why everybody's using these oral antihistamines and why they think people might be getting better. It's because it's mostly just placebo effect. Because there have been studies showing there's no high-level evidence to support these non-sedating antihistamines in the treatment of atopic dermatitis and other diseases, except for chronic spontaneous urticaria. But we do know that sedating antihistamines work, like Benadryl, diphenhydramine, hydroxyzine. But how do they work? They actually work by, you can look at this fMRI, activating brain areas that are associated with scratch relief. On the adverse side, there have been some reports of antihistamines causing dementia. So, important to think about anticholinergic effects as well in these patients. All the dermatologists know this, but just for the medicine docs, some of our go-tos for steroids. And then cooling agents that we use. A lot of these are over the counter, they're available, but sometimes we may not know how they work. So I thought it'd be helpful to show them. So there's cooling agents that are over the counter. And it's really cool. The way they work is they're modulating these ion channels, transient receptor potential ion channels. So there's one called TRPM8, and this is the actually receptor for menthol. So a lot of people know that menthol is used for itch, but this is why it works, because it's actually signaling through this transient receptor channel and distracting the neuron. So menthol, calamine, camphor, these are all available over the counter things that people use. People on inpatient floors use it, and it reduces activity of these ion channels, TRP ion channels. And actually menthol, there's some really nice papers about how it activates cold sensing peripheral neurons that then reduce itch sensation and awareness of itch in those peripheral neurons. So you can see those here, and you can see there's so many over-the-counter agents. I usually tell patients also to put it in the fridge if it doesn't work naturally, because then it cools it down even more, some of these pump bottles. Topical capsaicin, you guys have probably heard of it. Topical capsaicin is something I don't tell anybody to put on inflamed skin, only in normal appearing skin, more like neuropathic. So say a certain area on your arm or your back. I don't actually use a lot, but when I do use it, I tell them we know it's working because you're going to put it on and it's going to burn really, really bad for several days. And you're going to put it on a lot initially. And then after all the neuropeptides are released from the nerve endings, then it'll be depolarized the neurons and it'll help with the itching. So as a cream, don't utilize it that much. One of my colleagues in Germany actually used the patch for post-herpetic neuralgia and found that a single application for an hour off-label of a capsaicin patch was able for 3 months to reduce brachioradial pruritus and other forms of neuropathic itching. So when we can get it off-label, that's something really interesting that can help this neuropathic itching. There's so many anesthetics that are available over the counter, so I'll go through some of them. Pramoxine, this is available in a ton of over-the-counter preparations. It's a topical anesthetic. It's actually working by decreasing the sodium ions and reversibly binding the voltage-gated sodium channels. Remember, itch is like an electric current. So these anesthetics are able to block that sodium depolarization. You can actually use it many times a day, 3 to 4 times a day. It works quickly in a couple minutes, up to several hours. Low toxicity, many different formulations. These are all the different brands over the counter that have pramoxine in it, from scalp solutions just to over-the-counter creams, lotions. And what's interesting is there's a study here that looked at it in uremic pruritus itching, which you wouldn't think would be the right place to use it. But in this study, they used it twice a day to all areas of itching, so all over the body, and found a 61% decrease. So I've been a little bit more liberal, giving this to wider body areas many times a day to help people as just an initial step, especially for neuropathic itching. There's a lot of these lidocaine patches for pain that are available. And what patients taught me about a lot of these. One of my patients said, all the stuff you gave me didn't work, but which they tell me all the time. I get that a lot. But they found this spray that they said was really helpful, and it had a lot of lidocaine in it. So then I learned, and I've been able to give some of these patients some of these anesthetic sprays as well. There's the combinations of amitriptyline, ketamine, and lidocaine as well. We actually showed, we did an infusion for a ketamine patient, actually systemically, who had terrible neuropathic itch with anesthesia, which is really scary, but it worked great. And topically, it can work. So you can compound these creams, and you can compound them 5% and 5% combinations in a lipoderm cream from a compounding pharmacy. So say for neuropathic pruritus on the arms or back. You can also put in a scalp solution for someone who has terrible scalp itching. It's pretty straightforward to put in a solution. They can use it 2 to 3 times a day. I would just be careful because you can actually have an encephalopathy. If you apply the ketamine topically to a larger body surface area, it can be actually systemically absorbed and you can go nuts. So for erythromelalgia, they sometimes do lower doses. So you can be if you I'll start with lower dose. That's okay too. There's strontium that's available over the counter. I was a little skeptical of this, and sometimes it doesn't work, but sometimes it actually can help a little bit. So I thought it was important to at least mention it. It can compete with calcium for receptor binding because there's calcium-dependent depolarization of these C nerve fibers. So there's actually scalp solutions, and there's some creams and as an adjunct, because it's just really difficult to manage these patients having something in your back pocket that can help as well. There's oatmeal preparations that I know many of you know for neurogenic inflammation, actually been shown to reduce a lot of these cytokines and staph colonization as well. And then in dermatology, we have just an embarrassment of riches of new drugs. So all these are topical, non-steroidal agents that are available now. So ruxolitinib is a JAK1 and JAK2 inhibitor, works much faster than our go-to steroid triamcinolone. Roflumilast is approved for atopic dermatitis, psoriasis, seborrheic dermatitis, and it's a very potent phosphodiesterase 4 inhibitor. Tapinarof is the aryl hydrocarbon receptor, and we have another PDE4 inhibitor. So I wanted to share another story about a patient. I was rounding, and there was a patient who had a PD-1 inhibitor and had this terrible itching all over. All the normal suspects didn't work, antihistamines, et cetera, all the creams. So what we tried was a naloxone infusion, and we gave this to the patient. And what we found is that their itch immediately went down from a 10 to a 1 within an hour. And there's a continuous infusion of naloxone 48 hours. And after that time, we were able to maintain the patient on naltrexone daily. And it was very interesting because we've had a lot more success with the infusion of naloxone. But this study helped us open that door. Sometimes I give generic naltrexone, but I've been very unimpressed with its effects, and also terrible side effects. You just tell people they're going to feel terrible dizzy, GI problems, nausea. So one thing we've been doing a little bit more of is low-dose naltrexone. I thought this was just a bunch of baloney, but now I'm coming around to it. So there is some biology behind why low-dose naltrexone may work better, and that's that it modulates toll-like receptor 4 signaling. So you can see that at standard doses, you have opioid receptor antagonism, but at low doses, then you actually also modulate toll-like receptor 4 activity. And so there's a number of other diseases that come up, and toll-like receptor 4 is involved with TRP channels. So in dermatology, we've seen reports of Haley-Haley disease, a lot of other conditions, but this helps explain why low dose might actually work a little bit better. So there's a nice a study that another group had published about using 10 milligram tabs of naltrexone, just 10 of the 50 milligram tabs, and then crushing it into 16 ounce of orange juice using a 1 mg per ml solution. Our pharmacist wouldn't allow me to do that. So what we do instead is I give people 10 tabs of naltrexone and tell them just put in a water bottle. They're all 16 ounces, 500 cc's, 16 ounces, and then just take a teaspoon daily, which is 3 to 5 milligrams that they're getting. And that's been able to help or be an option for some patients, because oftentimes you're seeing these patients, nothing works, they're coming back, and you have to keep having things in your toolbox. So this is something else that you all can try. There's butorphanol, so inhaler. This is a nasty drug, so really unsafe, terrible drug. But I'm telling you because there's itch emergencies, things that you can do. So this is a drug that's approved for neuropathic pain. It's a kappa opioid agonist. And it's an inhaler. So if you inhale it, you put it in one of your nostrils, then you'll immediately get knocked out. So look at that, 43% somnolence and dizziness, and 20%. And nausea. Why am I telling you guys about this drug? Well, sometimes people have terrible itch and they need something to immediately calm them down. So we reported this as kappa opioid, that this is, and also another group has reported this as well, as being a rescue therapy. This is in my itch emergency categories. Again, not a long-term thing, but if I've had oftentimes some patients come in and say, I'm going to kill myself if you don't help me right now. And then you got to do something. So this is sometimes where we go. And a lot of other immunosuppressants, but we're entering a new age with less immunosuppressant therapy. There's all sorts of JAK inhibitors that are being approved right now. Many of you know about abrocitinib, upadacitinib. I can touch on this again later with the derm team, but this is my lab workup and baseline testing that I do for these patients, checking out kidney, liver function, blood counts as well. Then for more neuropathic itching, I use gabapentin. I usually start with 100 milligrams nightly, and then I titrate up because some people get really tired if you use it even at 300, especially if folks are a little bit older. So I usually start with 100 at night, and then you can go up to 4 or 5 days in the morning, midday, and slowly go up. I do have some patients on over 2,000 milligrams. Pregabalin, similar, low doses, 75 start at night, and then you go higher. All sorts of antidepressants. So like think about the HIV patient who's cachectic and itching all night. This is a good choice, mirtazapine and SNRI, because it helps them sleep and helps them gain a little bit more weight. Then you have a whole host of other drugs like duloxetine that does not cause sedation or weight gain that you can give in the mornings. Sometimes a combination, but there's, again, very poor data. We had a report of medical marijuana. So we actually had the world's first report of medical marijuana. I had a patient with cholestatic itching. We tried all these bile resins. We tried the butorphanol inhaler. That didn't work. And so I'd read some literature on endocannabinoids, and my resident was working with me, and I always wanted to get certified. So I was like, I'm going to get certified for medical marijuana to dispense it. And I gave it to the patient. I was in there counseling them. Well, you could saute your vegetables in this or gummy, but I don't recommend smoking. And then, one of my residents was like, okay, like I don't know where this counseling is going. But you can see just how significantly it works. So look at their itch, like it went from 10 all the way down to 0 when nothing else worked. Interestingly, though, for some reason, it's the liver-related itch, cholestatic itch. It didn't work as well on these other itch disorders. So we're trying to understand where that cannabinoid tone is, and people are using generics as well for that. And then last, I want to talk a little bit about what we're doing. So we have a really interesting structure. So I have a lot of labs, like bench labs, where we're doing mouse models and postdocs. And so we're studying itch biology in mice. There's some good itch mouse models where we do recordings, we do scratch bouts, and we genetically delete certain receptors, and we study itch. But I always thought this was incomplete research. So I also, obviously treat patients and we collect skin blood microbiome samples. And we've done a lot of studies on classifying new itch subtypes, peripheral blood, multi-omics, and then we take it back with clinical trials where we do therapeutics, targeted therapeutics for new trials as well. And this is another schematic. We actually have there's a cancer moonshot initiative. It sounds silly, but I have an itch moonshot initiative where the big problem we have is we haven't phenotyped all of our itch conditions. So we're trying to make an itch map, the human itch map. So every type of itch, we're going to have patients. Now I'm the chair. Nobody can stop me. I'm doing it. So I called him. I was like, this is what we're doing. I was like, I want to make an institute. And the dean was like, okay, fine. So we're like, every patient that walks through the door, is itchy. We're like getting our IRBs and everything up, and we're going to be collecting this seriously, and all like making these maps. And we have a lot of NIH. We have NIH support and other grants that are going in, and we're really passionate about trying to help move the field forward with that. And we had a lot of folks come by. We had NPR recently in Atlantic. We have PBS coming. We have a lot of patients internationally that are coming in, and we're treating these patients in our itch center right now that we're growing. So that's all I got. Thank you guys so much for having me. I can answer any questions or go through anything.
Dr. Williams, can you get the lights down?
Oh, I think so.
Very informative, thank you. For idiopathic itch, any genetic or like family history important?
Yeah, that's a great question. Well, you definitely want to know if there's any family members itching because scabies and all that stuff. Genetics, I think, are important for eczema, atopic dermatitis, because that's a common comorbidity in all these conditions. But not necessarily rare genetic syndromes unless there's a certain kind of skin phenotype. That's a really important question. Actually, it does in older adults who have this unique phenotype of itching. I have been asking a little bit more, and there's oftentimes other family members that are more likely to have it too. So that's a good question.
What do you think about bullous pemphigoid?
Great.
I don't think you mentioned that.
I didn't mention bullous pemphigoid as much, but all the time, and I'm seeing a ton of bullous pemphigoid that has no bullae, and then we get an indirect immunofluorescence from the blood, and it shows up. But what's interesting is they have high blood eosinophils too. They respond to dupilumab off-label, and there's positive trial. So to me, I'm like less categorizing these diseases as kind of their individual phenotypes, and I'm thinking about it more in terms of immune pathogenesis. And so I think bullous pemphigoid has this underlying backdrop of type 2 inflammation. So there's overlap with atopic derm, a lot of itching in general. And we'll be able to manage these patients as long as good therapeutics. But you're right, with blisters, but without blisters too. A lot of these older adult patients who are itching of unknown origin are actually bullous pemphigoid without the bullet. But I treat them very similarly. So.
And I probably, for the PI guys, we shouldn't leave out dermatitis piriformis.
Oh, no, that's a good one. Yeah.
Which is related to
elbows and celiac. Yeah. That's a great one.
So, seeing a lot of patients with renal dysfunction, we were taught back in the late 70s to use cyproheptadine, and you didn't mention that at all. And is it because it's really a drug with a lot of side effects, or just not effective?
I think a lot of side effects, and then I think also mechanism. This is a lot of what people told folks to do later on, but we're not seeing the same efficacy, and also sedation, side effects. Those are all some of the reasons we're staying away from it.
But sedation might be one. I mean, looking at all your mechanisms, that might be a major therapeutic effect. I mean, the one drug
exactly,
but 43% sedation. That's probably a good thing.
I really worry about dementia though. A lot of these patients later on, or some types of anticholinergic effects from them. Yeah.
But back here.
Yeah.
I was just gonna ask, do you ever get IgE levels and do omalizumab or?
You know what? It's a great question. I tried that in a few patients, but it didn't actually seem to be that if you have IgE, you necessarily respond to omalizumab if you don't have hive. So I actually think that the role of IgE is being redefined a little bit. There's actually IL-4, 13, and the basophils, the eosinophils, and mast cells actually have some upstream scripts that then cause IgE release. So I think that to me, I now view IgE as a biomarker of type 2 inflammation in general. So if you look across all the dupilumab treated patients, anybody who has high IgE, their IgE comes down if they respond to dupilumab treatment. So I'm not necessarily using IgE to help guide omalizumab, but more IgE is similar to like the blood eosinophil and it's conveying an immune phenotype. And it's not just dupilumab now. We have lebrikizumab approved, we have tralokinumab. We're going to have so many other drugs targeting that type 2 axis that I think that's been more helpful in guiding it.
Have you found a difference in efficacy with the dupilumab IL-4/13 or the pure IL-13 inhibitors? I know for me,
yeah.
the topic, I feel like sometimes the 4/13 works better, just
Yeah.
anecdotally, but I was curious about itch.
It's a great question. So it's the molecule. So the tralokinumab has half the efficacy of dupilumab because it doesn't target the drug effectively. But lebrikizumab very tightly binds IL-13. And if you look at the data, it's actually very similar to dupilumab, if not a little bit better. Or at least very similar. So I think you'll see the lebrikizumab, the new drug, actually targets itch very effectively. And IL-13 is very important. One thing that dupilumab does is it targets not only IL-4 and 13 in that IL-4 receptor complex, but it also has off-target activity. It targets IL-4 receptor in the gamma chain. And that's why you actually have some patients that have this head and neck dermatitis and other type 1 upregulation. So the thought is if you just target IL-13 and you have a potent molecule, maybe you'll reduce some of this, some of these adverse events and immune switching. We'll have to see if that's true, but it could be more selective.
For malignancy associated itch, I saw your flow sheet. You want to, I do have a patient where we did discover malignancy.
Oh, wow.
But he's being treated appropriately, but he's still itching severely. Is there a certain approach you use to these patients, or?
I've done this a lot because I treat a lot of PD-1 inhibitor patients too. And I think the NCCN is going to be updating their guidelines for biologic therapy, targeted therapy. So I use a lot of dupilumab, but then now tralokinumab, lebrikizumab, nemolizumab, all these 1 receptor targets that are not globally immunosuppressive, I think is the way to go.
And these patients don't need to necessarily have the elevated IgE, like you said?
No. Again, these biomarkers are not perfect. They're all just, and there's many patients that have immune itch but don't have the biomarkers, but it just is something to help us. Because when it is high, I'll say it this way, I've never had an itch patient ever that I haven't been able to improve that has high eosinophils and IG because we have a lot of immune tools. So it's just helpful for you. But I would say biologic therapy is the way to go if you have malignancy because it's targeted on the cytokine versus anything immunosuppressive across, you don't immunosuppress them.
Yeah, it makes sense. He's already on multiple chemos. So
yeah. Especially dupilumab. We just published a number of reports about a lot of these PD-1 patients treated with it, and a lot of other people have published that too.
Thank you.
Right. Great. This was actually pretty amazing, very comprehensive, and learned so much more about mechanisms than we got. I mean, it's not just the evaluation of the therapy, but it's how to think about how to go forward, which, so congratulations on all that you're doing and all that innovation. That's a massive number of publications with your name on it. I think that was pretty good. I think we really appreciate that. Thank you.